hope will be educational, or at least informative. This was a case that I did about a month ago. A 60-year-old male who was referred to me by my heart failure transplant colleagues at Stanford had a past history of an inherited dilated cardiomyopathy. His brother had previously been transplanted. His father had received a transplant prior to that, so certainly an inherited issue there. He had a defibrillator placed at the time, prior to his surgery, and then replaced at the time of surgery. He had an MVR and a tricuspid valve replacement, both with perimount 33mm valves. He had a history of atrial fibrillation. At the time of his valve surgery, he also had left atrial appendage ligation. He had dyslipidemia, and importantly, he had a myelodysplastic syndrome and was on steroid therapy intermittently. So he was referred to me, 60 years old, quite functionally active. He had stopped work just because of a progressive increase in his symptoms. He was now sort of class 3 to 4 with profound fatigue, could no longer work. There were plans to transplant him at some point. At the time of evaluation, his ejection fraction wasn't bad enough, about 40 to 45%. He had compensated well. It was an appropriate medical therapy. When I saw him in the clinic, he had bilateral pitting edema to the mid-thighs, significant abdominal fullness with ascites, and was complaining of nausea and reduced appetite. And this sort of decline had occurred over the prior 6 to 12 months. His echocardiogram here shows, you can see the lead shadowing, and then also significant tricuspid regurgitation, so bioprosthetic tricuspid regurgitation. So we had a discussion with the heart team, and the family were not so keen for surgery. He'd already had previous valve surgery, and from the surgeon's point of view, likely that he would need a transplant in the forthcoming years, and so we want to avoid the time of transplant being a second redo. So they referred him to me for consideration of a transcatheter approach. So my first concern was what to do about that lead. Now, fortunately for me, at the time of his surgery, the surgeon had had the foresight to place his replacement lead outside the surgical ring, which took away a lot of my concern about potential fracture of the lead if I was to do a valve and ring or valve procedure. So I got a CT, and unfortunately I don't have the images, but that confirmed that the lead was indeed outside the surgical prosthesis, so I was reassured by that. I then proposed to the patient that we put in a 29mm Sapien 3 device on the Ultra delivery system. Now, the Ultra delivery system is not available here in India, but basically, you saw in the case before, the valve needs to be mounted on the balloon. With the Ultra delivery system, it comes pre-mounted, so there's no need to load it or manipulate a balloon. It comes pre-loaded, and there's no push catheter. Samir Kapadia and colleagues have described doing these tricuspid valve and valving procedures from the internal jugular approach. It's a straighter shot anatomically down to the valve and certainly more coaxial. However, I haven't tried it from an internal jugular approach. I think from a logistical point of view, it's a lot more cumbersome when you've got anesthesia and trying to work, especially now in cath labs at Stanford, it's a little more difficult. So I elected to go from a transvenous femoral approach. With my mitrals or with my tricuspids, I don't generally rapid pace. The low flow, low pressure system doesn't really necessitate it. And in this case, I would have had to potentially either overdrive pace through his device or put in, as has been described in literature, a transarterial pacing wire via the aortic valve into the left ventricle. And I thought neither was necessary, and so I had no plans for rapid pacing, and the procedure was done under MAC in terms of the anesthetic support. So the valve app doesn't have a tricuspid aspect, but it certainly has a mitral, and so based on the recommendations for a 33 mosaic, you can see there is to use a 29mm Sapien 3. It's quite a large valve, a 28 True ID, and the optimal position from a mitral perspective, so similar to crossover to the tricuspid perspective, is again just to have it a couple of millimeters above the top of the valve there. And the valve's fairly easy to see with the presence of those 3 islets. So this was my approach. I used an Agilis catheter for steering sometimes with these patients with tricuspid regurgitation because of that very sort of torrential jet. It might be hard to cross the defect even though it's wide open. The Agilis just provides support and steerability. I then used a multi-purpose catheter through the Agilis and was able to navigate through there. This is just the on-fast view to show that I'm truly through the valve. We've seen all these disaster cases where sometimes you go down the side of the valve. Remembering there is a lead next to this valve, so there is a potential space. I didn't want to pass a wire down paravalvular. I wanted to make sure I was indeed through the valve. I then placed a Amplatz extra stiff wire through the tricuspid valve via the artery outflow tract into the pulmonary artery and buried it out there. So I wanted a good rail of support. Now, some people will place a feeder wire in the right ventricle itself. The reason I didn't elect to do that is because the right ventricle is a lot thinner than the left ventricle. The feeder wire, for those of us who've done many procedure, does sometimes cause laceration even in the left ventricle, which is a thicker structure. And I didn't want to take that risk with all the moving around to place it in the right ventricle. And I also wanted a bit more support, and so I took the wire out to the pulmonary artery. At this point, as I said, initially my plan was to take the SAPIEN 3 with the ultra delivery system. At the time, now there's been a class 1 recall of the SAPIEN 3 ultra delivery system, but at the time, some of my colleagues were having issues with the ultra delivery system. So I sort of got convinced into going back to using the S3 with the commanded delivery system, which is what you saw here. And that was something important in the way this case turned out. So you can see there I managed to get the SAPIEN 3 device to the level of the valve. However, the problem was every time I tried to take that pusher back, and I don't have videos of this, the valve would come back. And I tried various combinations of pushing it deeper into the ventricle and it would not go. I tried various combinations of pulling the pusher back to change the stiffness of the device and it wouldn't go. I tried everything I could with that same wire apparatus. I also confirmed that I wasn't, in case I was on perivalvular and getting stuck, it's important to make sure that doesn't happen. We saw cases yesterday of valve embolization because of that. And indeed, I was through the valve still. So because my nose cone was across, what I elected to do was change my wire for additional stiffness. So through the nose cone of the device, without pulling the device out, I placed a Lundequist straight curve wire out in the same position, so the Lundequist being stiffer than the Amplatz extra stiff for a rail. However, even this didn't do the trick. So finally, I pulled the device out and went with my original plan, which is my original instinct to take the SAPIEN 3 Ultra device. And I also switched back to the Amplatz extra stiff because I didn't want such a stiff Lundequist in placing the stress on it. Managed to get the valve in the ideal position. Very slow inflation, no rapid pacing, and you can see that I'm advancing the valve as it's coming back, just to ensure that my final position is a couple of millimeters above the top of the ring there. And you see complete inflation of the valve. I'm very pleased with the final result. Very slow, very controlled inflation. This was the echocardiogram afterwards. You can see there great forward flow from the right atrium to the right ventricle and really trace central tricuspid regurgitation there. So I saw the patient at 1 month follow-up, trivial central TR on the repeat echocardiogram, no perivalvular leak. His peripheral edema had dramatically reduced. Remember, it was to the mid-thigh, was now trace at the ankles. His abdominal fullness and ascites had disappeared completely. He no longer had nausea and return of his appetite. And most importantly for him, he was able to return to a reduced, albeit reduced level of work, but still able to get back to doing some work, and now with class 2 symptoms with improved exercise tolerance. So what did I learn from this case? Like all of these structural cases, pre-procedural planning is paramount. And using imaging is very important. In this case, I used imaging to confirm the fact that the lead was outside the valve, but also to confirm the dimensions of the valve. Sometimes the reported valve that's put in is not necessarily accurate, so I always confirm with the patient, and then I get my team to ring the company to ensure that the stated valve in the notes is actually the valve in the patient's body. Appropriate wire selection. So starting off with a Amplatz extra stiff, which is my workhorse for most transcatheter therapies, and then knowing when to escalate to a super stiff or a Meyer wire or a Lundequist wire, but also appreciating that as you increase in stiffness, so too does the risk associated with a stiffer wire. It's important to have appropriate backup and support, and again, that decision process of whether to leave a wire in the right ventricle or to extend the wire out into the pulmonary artery for a longer rail. Have alternative approaches. When something doesn't work the first time, you need to be able to problem solve. You know, the definition of insanity is doing the same thing again and again, expecting a different result. And so you need to have a second and a third tier plan, particularly in these slightly more challenging cases. And then finally, the lesson I learned here was to go with my initial instinct. My initial instinct was to go with the valve that I like using, the delivery support that I have success with, and I was sort of gently coerced into doing otherwise because of some of my colleagues' concerns. And in the end, I went back to what I knew best, and it worked well. But nevertheless, we continue to learn from every case. Thank you for your attention.
Chennai was the start of advanced cardiac care in this country. That's where it started from. I mean, Scots came in 2 years, 3 years later than Apollo, but Apollo had set standards by that time. So a really pleasure to be here with great friends. I have Segutuvelu with me. I have Vijay, my colleague, in charge of our TAVR program at the Scots Heart Institute with me, Fortis Scots Heart Institute. And so we have a case here, which I think Secretary is going to tell you about.
Can you have the slides, please? Yeah, so he's a 56-year-old male and known diabetic. So he was diagnosed to have a cryptogenic cirrhosis. He has had status of pancreatic duodenectomy done earlier and has severe aortic stenosis. The LV function is normal. The STS score is low, but in view of the cirrhosis,
now a 14 French
turned down surgery, and he was highly symptomatic.
So we can have the sheath dilator and then the sheath itself. Yeah, go ahead.
And also he had mild esophageal varices, so the ECG shows there is no conduction disturbances in the pre-procedure ECG. So with a highly symptomatic severe aortic stenosis, with the history of cirrhosis, we thought we should definitely consider a transcatheter aortic valve replacement. So echo is clearly showing a valve area of 0.7 square centimeters, the mean gradient of 52. So, and he also has moderate aortic regurgitation.
Does it not need it on the 14th?
The next slide. So his coronary angiogram was normal. Just click on some minimal disease, no significant disease. The right coronary has some minimal disease. So next slide. So it's not that he has got severe aortic stenosis conjunctiva. We thought we should consider under conscious sedation, because in this case he has esophageal varices and there is no question of putting a TE inside. So we are doing a transthoracic echo, and we have Dr. Chandrasekhar with us for the echo. So do you want to show a bit of transthoracic echo straight away to them and live, and then go to the CT?
Live?
Yeah, we are live now.
Yeah, it is here.
Can you show the echo? The echo is already there on the screen. You can show. Go ahead. Yes, you are live. You can see the echo.
Well, I think here is the LV. As you can see, there is the LVH, and LV function is very good. And LA, mitral annular calcification, and RV is also normal. And you can here see the LV outflow tract. As you know, the patient is on the table supine, so the windows may not be appropriate. Nevertheless, the views are pretty good. LV, aortic root, and aorta, and you can see the regurgitation. And they got the gradient, which was basically, this is a two-chamber view. I'm going over quickly, and
I need an artery force.
so here is the gradient. You can see the peak gradient is about 82, mean gradient of 52, and I think essentially he's got severe aortic stenosis, and there's no other issues regarding this. I think I could show you the aortic root annulus measurement, but I think it was already done earlier and I didn't do it right now. So next I can show it to you later on.
So we'll move to the CT now. Can you show the slides back? So do you want to discuss the CT? So we have the CT is done, and you can see you can show the first slide, previous slide. So he's got a large annulus. The perimeter is 89. And the sinuses are adequate. Sinuses are adequate, and the coronary heights are quite 17 and 13, so quite high. And the perimeter derived diameter is 28.2, and the femorals are very good, well sized, very big sized vessels, and no calcification.
Yeah,
you can see the annulus. Not much of calcium, the LVOT, there's no calcium, no significant calcium. It's a tricuspid valve. The coronary heights are good, you can take over.
Yeah. So you just heard the history. So it's clearly a 34 millimeter valve. And we have our, so I think because it's step by step, I think we need to understand. So you saw yesterday ultrasound guided puncture. Let's show you because not everybody is trained in ultrasound. It requires adequate extent of training. It's a good idea, but it's not invariable. So let's go to the first shot here. And we've done more than 150 cases with our methodology of placing the pigtail and then having a bullseye. Now when you have the pigtail and face, and if you actually hit it absolutely in the bullseye, you've got to be anterior. And you've got to be central. So that's it. You just see the next shot. That's a micropuncture needle. So with the pigtail, I use a micropuncture needle for safety. You can see I've hit a bullseye, and you actually have a micropuncture needle. You don't hit a bullseye, you have the safety of a micropuncture. So certainly, in most instances, I don't believe that we do need ultrasound guided puncture. Yes, if you got atheroma, if you got calcification, you might want to do that. So it's a good thing to train on, but there are simpler methodologies to do this job. Okay. So we've now got our 14 French sheath in on our right side, which is our access side. We've got a pacing wire from the top, and we have a venous and an arterial on the left side, and we're now putting our pigtail into the non-coronary sinus. Okay? Our plan is to put a 34 millimeter evolute R in this patient. Okay, so we've got this here. How do you actually position in the non-coronary cusp? Can we connect it to the injector?
Yeah, that's the one.
That's the one? Flush on? Yeah, thank you. And show me just a bit more. Thank you. And can we suck back? There is a bubble. Okay, so there's a bubble here. So one of the things I prefer is to be able to have a 3-way, but anyway, this is fine. Okay, come back. Good. So the way you want to do it is just give it a rotated, and it should be it should be like this, it should be facing you. That's the way it goes into the right coronary sinus. Come to the RO and see whether you actually go into the right coronary sinus. RO.
You mean not coronary?
Yeah, so I want him to come to the RO so that you actually...
No more RO.
RO.
Little more RO.
Yeah, come to the RO, and now just give me a puff to see whether so this is the best view to tell you whether you're actually in the non-coronary cusp. So can we, so don't enlarge it, okay, you want to enlarge it, do it, but give me an injection. Okay, ready? Just to check that you're in the non-coronary cusp. Inject, just a puff, that's right. So we are in the non-coronary cusp, and I've pushed it into the non-coronary cusp. So now you can go back to our implanters view. What was the implanters? RAO8 and caudal 2. So we'll go to RAO8 and caudal 2. We've heparinized our patient now completely. I always, when I put the sheets in, I have them on 2000 heparin. It's never a situation of 0 heparin, but I always have it on heparin. And I always want to emphasize that you've got to keep flushing the sheets. While we may be talking, I actually want to see that the sheets are always flushed, irrespective of heparinization. Okay? Because these are large sheets with dead spaces in them. And if you actually have thrombus in the dead space, you then create. Are we in the implanters view? Okay. So I'm going to now take a cine with a 20 ml contrast. Okay. Is this 8 and 2? Okay, good. Are we ready to inject? So, any discussions on what we're doing?
Yeah, It's fine, actually. I like the way that you were very careful in placing the pigtail at the right non-coronary cusp, which is the lowest in the
Right, thank you. I think meticulous approach,
Yeah,
and
but
what I'm going to
most
demonstrate
of us
is
don't
that
do-
we double check everything.
Yeah, but we don't do an
We
angiogram
double check.
in aortic room. Just 20 cc is fine, but we like to preserve contact. This patient's 51, so it's fine. In older patients, I use less contact.
Yeah, that's right. So here's the situation. The 20 cc contrast can be even 10, can be even 5, depending on. Here we're not so concerned. Basic is you just want to be sure that you actually have the cusps outlined. You want to see the coronaries. You want to see anatomy for once. That's all. Ready? Okay. So we're going to go for that. Inject. So we're happy with this view. Because once the valve is there, we will actually remove the parallax. But at least what we know is that we're sitting nicely in the non-coronary cusp, which for evolutar is absolute must. Because that's your guide. That's how you actually get there. It doesn't mean you can't do it without it, but that perhaps is your biggest standard of guidance. Okay. So here is our AL1. All we then need is, and can we actually have an ACT? So, and then we actually, on an AL1, all you need to do is have this wire. The way to actually cross the valve, and I think this is an important aspect, is to rotate it from the non-coronary cusp towards the right coronary cusp, and then you would cross it. Okay, so let's, and it should, in most instances, it's usually a situation where you would be able to cross it within, hopefully. But these are always great to see online. When it's always there. Yeah. So normally it takes less than a minute to cross the valves. But then once you cross the valve, come into the RAO projection. Can you come into the RAO? Having come into the RAO projection, you know the valve is there, but you've got to be very careful that you could actually go through a cordy, and then, but you would know that once you put and the reason I then put a pigtail after that, okay, let's measure the hemodynamics now, but I can do it on the pigtail. So let's give an exchange wire. So what you now need to do, and never take a shortcut. I mean, I normally put confida on this, but I don't want to demonstrate to you shortcuts. It's okay. The topics are a part of life.
And Saibal, what do you think, whether you need to you pre-dilate these valves or you do direct implantation?
Usually if the gradients are very severe, I would pre-dilate, but this patient, there wasn't much of calcification. It's a trileaflet valve, so I wouldn't dilate. And also remember, the gradient is so high, partly because it's got cirrhosis of liver, which is a high flow state, and AI. So I think I wouldn't dilate this valve.
Sure. So on the teaching steps, while we can put the confida through the amplats by curving it upwards, don't take a shortcut, because let me just guide you. I always take on my table, every wire is always an exchange wire. It's never 035. I never want to be in a situation Okay, holding, where suddenly somebody passes me a non-exchange wire. Now, so it's simple to actually have a process which never fails, okay? Okay, so here we are, and see, if it's sitting nicely at the apex, then we'll find it hasn't got through the body. Flush.
Ashok, I really appreciate this move that you did. This is very important. People try to cut quick, to cut corners
This is
and
contrast.
then get stuck in cords. It's not
Yeah.
that thing.
Contrast is connected here. This is a special line.
Yeah, it's also what. So now we're measuring the hemodynamics, and let's see what we actually have.
You can't see it.
So you can see now the hemodynamics. Yes. Can we show that on the screen?
Can you
Can you
put
show
it
us
on
the
the
screen,
main
please, the hemodynamics?
Can you change the colors because you can't see
Yeah,
the
we'll put it on the
visual.
main screen.
Andrew, can you change the color to yellow or something?
What is
So,
coming
so it's heartening to see that we
Yes.
do have severe aortic stenosis. We have a gradient of 60 millimeters peak to peak, and our EDP is around 22.
You can also see that the diastolic
very
pressure is very
25.
low, which means he also has a lot of AI.
Correct?
And the LVDP is low.
So we are, yeah.
But I
So
still
I think we
that
have now-
the
so
gradient
what's-
is slightly overestimated because of the high flow state of cirrhosis. But it's
That, you can see that, and there is a high flow state because the systolic pressures are themselves up.
Yeah. You see a white pulse pressure, see that?
So,
It's
so
white pulse pressure.
Yes. And so now we actually will now move to, have you seen that? So now we can get that off. We have everything, and now we're going to put the confida wire, but I want to emphasize one thing. You want to actually be sure that the valve is there. Don't leave the confida wire and then start checking the valve. See, once you're across the valve, then you know that you're going to do a tap. Once you're going to do that, why would you want to splint the valve with a confida wire and then wait around? Confida wire is to take the valve in. You are most comfortable with this pigtail inside. So the valve should be checked prior to putting the confida wire and not after putting the confida wire. I hope you've understood that. That wire splits the aortic valve. You don't want to increase the torrential AI while you're hanging around. Okay, so let's go up, and let's hope that our Medtronic colleagues done a good job. And you can see that as you rotate around, the 3 checks you do is the paddles should be equal, the grounds should be parallel, and Vijay, what else? And that's right. And we have a good load. Okay?
Can you show them the valve for many of the beginners there in the hall? Can you focus on the valve so where the nose is going?
Okay. So firstly, all of you see those paddles. Actually, let me just get the paddles. Yeah, there we are. That's right. Okay, so let me show you the valve itself.
Can you
Store
focus the
safe.
camera down? Yeah, focus the camera.
So this is a great valve. This
Make it
is
a
a
big
low
screen.
profile valve. You can see that this is true 14 French. And this is a 34, so this is going to be a 16 French. Yeah, so this is a 16 French, but it's true 16 French. It's low profile. And therefore, I think it's totally user-friendly. So we've checked the valve. I like the valve because it's recapturable. I like the valve because it's easily deployable. And I think for a beginner, this is the easiest valve to train on. And then when you grow in experience, then you can get to, because Sapien has a lot of steps to it. And once implanted, it works well, but getting its implant becomes a more difficult problem in the early stages. So I'd rather that you get tuned to a simpler valve in the initial stages, and then you can do whatever you want as you go on. Okay, let's have a confida wire.
Here's the confida wire.
Now it's absolutely...
So you can show them the confida wire, pre-shaped wire. Just show the camera.
So here is the confida wire. I've always used a confida because I've had a single complication. And in more than close to 150 cases, and that's actually happened based on the wire. So I'm very careful about using a pre-shaped vase. So Vijay says that it's not just the pre-shape, there's no shaft angle to it, but I actually believe that that you can shape wires, but in the initial stages, I rather that you start being comfortable with a pre-shaped wire, so that you have one less thing to learn in life. We can now shape wires in a very nice manner. RAO. Always go to RAO to position your wire. You want to see your wire.
Ashok, we'll probably
Absolutely.
be moving to the other side. So, do you want us to break here? And
Yeah.
then come back, or
See, you can, because we soon going to be actually taking the valve now.
Okay.
So let's finish this. We didn't watch that.
And it's going to be a direct implantation.
It's a direct implantation, so you might as well. So remember, RAO, you have this, and you have to have a clear loop. If you haven't got a clear loop, you actually get it all out because you've gone through the cordia. This is one thing that you spend time on, and that itself is clearly, you've got to spend time on the fact, because wire position makes all the difference to avoid complications. And I'm very happy with this wire position and RAR Same to you.
Yeah, it looks very good.
So now we actually taking our 14 French sheath out and going with an inline sheath. So step by step is what I'm demonstrating. I'm actually pretty good. So here is a sheath comes out. Your wire should be always under your vision.
So
Yeah.
here we have a very large femorals and iliac. So we have the options of using even a larger sheath, but this makes it much more easier because we're using an inline sheath. We have a very small diameter of 16 French. But in case we have some tortuosities or we feel...
Yeah, and if you needed a pre-dilatation, it was a... So if you needed multiple steps, I would have used... Okay, now hold the wire. Then I would have used, okay, and that's gone in, and now the inline sheath goes in. So this is... So the biggest issue around this is one single fact. It's smooth.
Show down.
And I know it's large, so we can actually show downwards.
And the wire both again.
And if we can actually have unmagnified so that we can see the wire at the same time. Now show the wire at the top. Absolutely this. And because I'm not facing any resistance, I can actually go neatly, and Vijay, you can hold the wire, and I'm actually in. Okay? Why are we seeing so many ectopics? Okay, so the wire is okay. So here it is. We're ready to actually go across. We have our valve well aligned, and now we can just see the aortic arch. Aortic arch, top.
More, show up, please show up. And more little LAO also. Go up.
Correct? And go LAO. So you want, I'm taking you slowly through the steps, LAO, because this is to understand the best practices. I'm not going to take any shortcut. Can you unmagnify? And unmagnify one more, because what you want to do is see the whole aortic arch. Okay? So now the next thing is, before you go across, firstly make sure your pigtail hasn't moved, but it could actually move once you get the valve across. So that's the second thing to note. Okay, so Vijay, you holding this? Okay, so here I'm going across. I tell my colleague to only concentrate on the wire and never on the valve. The valve is my issue. His issue is only the wire, okay? So Vijay, hold it, and you actually have to keep a tug on it because that's the only way to cross it. And luckily my pigtail hasn't moved. We're looking at the pressures, and I now need, I will now get the band, remove the parallax. So can we remove the parallax? Yeah, so that's it, it's done. And now all I need is a buff, a contrast. So somebody should always be at a contrast. For an evolute R, it is a must to sit there and make sure your pigtail is in the right position. Can you give me a buff? Just 5 ml? So we are actually sitting there. Okay. So we should be ready to go. Now what do we actually want to do? Pressures are okay, so I can talk. What we want with the 34 is it's got a tendency to dive in. So actually make sure that enough wire is in, which it is at the moment. And secondly, that we're going to make sure that we are coaxial, and then we will go on to release the valve. So give me a 10 ml injection, and then we actually go.
And do you want to consider pacing, or you want to...
We will be pacing. You're absolutely right, Secretary. Once we actually have an apposition, we'll be pacing. So can we give an injection, a proper injection? That's good. That's good. Okay. So we're starting at 3 to 5 millimeters, and that's what we're going to do. So Vijay, we're going to start unsheathing the valve. There's no rush. Pressures are good. Keep, it's all, there's no rush about it, so you can actually now keep on unsheathing. So we are unsheathing the valve, as you can see, keep coming back, coming back, coming back. And we are still in the right position. Okay, keep coming back. And we will let it flare a bit. And then we will check the position. Yeah, that's okay, just leave it now. So here is where I take a breather and say, okay, are we in the right position? And yes, we're in the right position. Give me a good buff. Give me contrast. Yeah, so I think I'm a bit shallow. So I just pushed it in. Can we fluoro save that? And you can have a look at it. Yeah. Play that. Okay, because from here on, I'm just going to... Sorry about that. I thought yeah, that's right. So this is slightly shallow, but this should be fine. So can we move it further?
Would you like this? I don't think you should.
Can we release it further? Yeah. Yeah. Vijay is okay. Now just hold it there. Just hold it there, Vijay. One injection, because after this it's pacing, and after that it's going to be till where we go. So now we're going to record this. Okay, go ahead. Yeah.
No, not so high. We'll see. We'll burn.
So I'm good with this. And okay, pace at 130. You're not pacing at 130.
Not pacing the lead position. Is it okay? Can you increase the output? Yeah.
Okay, pace at 140. Okay, Vijay, you're ready to go. So I'm actually got this on, so that Vijay can actually unsheath the valve and come to that, and a bit more and a bit more and a bit more, and stop. Okay, press spacing off. So now we are actually 80% deployed. There's no rush. Let the pressures come up. we're looking good. And then we will actually check. Let the pressures come. You see, once you got this, what you want is, there's no rush. You let the valve breathe. And now we will actually see where we are.
Contrast
Okay.
injection.
So let's look at the echo first. So two things happen. A 10 ml contrast injection, can we have that? Okay, I've taken it on a cine.
But it's okay. It's not
On the
deployer. It'll
Yeah.
shift up.
So here are the two things that you've got to do. Firstly, look at the echo and look at the parallax and remove the parallax. We are looking at our hemodynamics. Can you show them the arterial pressures? So that's not bad in terms of the diastolic pressures, but we will change the parallax and then do the injection. Sorry, where is it? Remove the parallax and then do the injection.
Can you show the echo in a bigger screen?
Yeah, we're going to see the echo. I can bring it back a bit more, and I would probably do that, but let's first let's remove the parallax and look at the valve.
Can you remove the
What do you
parallax?
think?
Just fluoro and remove the parallax.
5 minutes more.
Okay. So let's remove the parallax now.
And
Okay, can we go caudal now?
caudal.
No. Don't change the angulation. Go to the same LAO a bit, and then now go cranial. Cranial, a bit more cranial.
27.3.
A bit more cranial. Yeah, and now come RAO a bit. Now let's look at the fact whether we've removed the parallax. I think we have. So I'm going to take a cine here.
We see the fluoro.
No, we
because
haven't.
The other lab is also ready, so
So we have a couple of minutes more, so take your time and we will probably move over to the next lab in a couple of minutes.
Okay. So I think the valve is deep. We're going to capture it, bring it more shallow. But we've not got the parallax off. Can we actually have the parallax?
Can
Move,
we see,
move,
we see the
move,
fluoro,
can we
please.
see the fluoro?
Can you get them the fluoro?
Yeah. Yeah, it looks deep.
Particularly on the left side.
Yeah. Well, the
So
left
let's
side
come
now
back.
is correct, but
And
even
now-
on the right side it's deep.
Yeah, that will correct. No, on the right side is deep.
Yeah.
So we're actually going to be more shallow than this.
Okay, I agree with
But
you.
I'm still not sure whether the parallax is off.